Welcome to this new session of Transplant International Podcast.
Hi, and welcome everyone. Welcome to the Transplant International Podcast, where we explore innovations in clinical organ transplantation and cutting-edge translational research. I'm your host, Nina Pilat. I'm Deputy Editor-in-Chief of Transplant International, and thank you for joining us today for this January issue episode. Today, we're focusing on a topic that has shaped transplant strategy for decades. It's simultaneous pancreas-kidney transplantation, or SPK, versus kidney transplants alone in patients with diabetes and end-stage kidney diseases. Our January issue features 2 original articles and 3 commentaries on this topic, and it's also highlighted on our covers. So historically, registry and code studies suggested that SPK offers a survival advantage compared to kidney alone transplantation. But 2 new large contemporary analyses, one using a global EHR network and one from the US SRTR registry, they aim to challenge how we should interpret that advantage in a modern era. To guide us through the data and, more importantly, what it means in clinical practice, I'm very happy to be joined by Dr. Delphine Kervella. Today, she's a nephrologist and one of our Transplant International Editorial Fellows. So, Delphine, welcome to our podcast. I'm so glad you could join us today.
Thank you, Nina. It's a pleasure to be here and to discuss this really important topic.
Before we move on into the discussion, we wish to state that the views expressed in our podcast, they are our own and do not necessarily reflect those of Transplant International or research. So let's start with the clinical question we face at the bedside. For a 35 or 45-year-old patient with diabetes and end-stage kidney disease, what are the main transplant options and how do we usually think of them?
So in this setting, the key decision is whether to proceed with a simultaneous pancreas-kidney transplantation, what we call SPK, or keep up with a kidney transplant alone from a deceased donor or a living donor. SPK offers the unique possibility of insulin independence and near physiologic glycemic control. It can reduce the glycemic variability and hypoglycemia burden and might provide long-term protection against microvascular and macrovascular complications. Historically, SPK indication was restricted to type 1 diabetes, but it has been extended to selected type 2 diabetes patients in some countries like the US. However, SPK is surgically more complex with higher early perioperative risk. There are more complications and hospital readmissions in the first year, and also it uses a scarce pancreas graft. On the other hand, we have kidney transplant alone, and it's technically simpler and carries a lower early procedural risk. And the context has changed also. Diabetes care has improved dramatically in the recent years with new therapies, and especially in type 1 diabetes, we have better insulin delivery systems and continuous glucose monitoring. So the contemporary question is really, in an era of optimized kidney transplantation and advanced diabetes management, does SPK still provide a true survival advantage, or is its main benefit now metabolic and quality of life related?
So as we frame the clinical question, we move on to the first major study in this issue by Catarinella and colleagues titled Simultaneous Pancreas-Kidney versus Kidney Transplant Alone, Real-World Outcomes in a Propensity-Matched Global Cohort. Delphine, could you walk us through the design of this study first?
Of course. So this was a retrospective analysis using the TriNetX Global Federated EHR network covering 2010 to 2024. The authors included adults aged 18 to 59 years with diabetes and end-stage renal disease who underwent deceased donor transplantation only. And the cohort comprised 3,679 SPK recipients, about half of them with type 1 diabetes, and on the other hand, 27,062 kidney alone recipients. Because the baseline characteristics were very different, particularly for diabetes type, obesity, and age, they performed one-to-one propensity score matching. They included detailed recipient variables and some donor covariates to balance the groups as much as possible. So after matching, they obtained comparable groups, and the median follow-up was around 6 years.
So what did they see before doing any matching?
Before matching, SPK looked clearly superior. lower mortality, fewer cardiovascular events, and better kidney graft survival. But this is exactly where selection bias comes in. SPK recipients were younger, leaner, more often type 1 diabetes, and with fewer comorbidities. So the question is this a treatment effect, or are we just seeing the effect of how patients were selected for SPK?
So once they adjusted for those differences with propensity matching, what happened to the results?
So after matching, it's clearly different. This is a survival advantage essentially disappeared. Regarding patient survival, the hazard ratio was around 1. There was no difference up to 10 years. Regarding kidney graft survival, the hazard ratio around 0.99, again, neutral. And for cardiovascular events, the hazard ratio was also close to 0.99, again, no significant difference. So once the baseline differences were balanced, it seems that overall survival and major cardiovascular outcomes were neutral between SPK and kidney transplantation alone.
Okay, but yet the story isn't purely neutral. So it's patients. It's also a quality of life question. So the metabolic outcomes, they still favored SPK, right?
Yeah, so that's an interesting point of this study, is that they included also metabolic data. And if we look at it, SPK was clearly superior. For example, the HbA1c remained consistently lower in SPK recipients, around 6.2% versus 6.5% at 5 years, which was significant. Insulin independence was also durable in the SPK group. So metabolically, SPK performed clearly better, and this benefit persisted over time.
And about early morbidity in that study, was there a difference?
Yeah, so that's what we know also from previous data. But here in this study again, SPK was associated with higher rates of perioperative complications and infections. And after matching, these differences were attenuated but did not disappear. They remain a higher early morbidity signal in SPK. They also performed sensitivity analysis to restrict the cohort to type 1 diabetes patients and further to lean type 1 diabetes patients with a BMI of less than 30. And even in these more classic SPK subgroups, the survival remained neutral. So there were no clear SPK survival advantage.
So how would you summarize the message from the global EHR analysis here?
I would say that in this large real-world dataset, once the selection bias is minimized through careful matching between groups, SPK does not show a clear overall survival advantage compared to deceased donor kidney alone transplantation over a median of 6 years. However, SPK delivers robust and durable metabolic superiority at the cost of this higher early morbidity.
And if we turn to the second major article, which uses a different data source and methodology, the study by Kervella and colleagues, it's reassessing simultaneous pancreas-kidney versus kidney alone, a propensity-weighted analysis of survival and mortality. They used SRTR data from 2014 to 2023. What's methodologically distinct about these analyses?
So for the 7 articles, there are 2 main differences compared to the TriNetX study. First, this is based on the US National Transplant Registry, so the SRTR, including more than 22,000 recipients with diabetes. About 25% of them received SPK and 75% a deceased donor kidney alone. And second, instead of this one-to-one propensity matching we've seen in the previous study, here they used an overlap propensity score weighting. So this technique is particularly useful when the 2 groups are quite different and there is limited covariate overlap. So it focuses the analysis on patients for whom either treatment would have been plausible, aiming to reduce bias and variance. So to do so, they incorporated a rich set of covariates, including donor kidney quality, dialysis duration, and other donor and recipient factors, including, of course, type 1 diabetes.
And again, the baseline differences between the SPK and the kidney alone, they were substantial.
Yes, of course, like we've seen in previous article here in the unadjusted data, SPK recipients were younger, they were more often type 1 diabetics, about 80%, they had lower BMI, a shorter dialysis exposure before transplant, And they also received what we can call better quality kidneys with lower KDPI. So as in the EHR study, a raw and adjusted comparison strongly favors SPK, but is heavily co-founded.
And here, what did the authors find after applying their overlap weighting?
So after adjustment, 5 and 10-year patient survival were essentially identical between SPK and kidney alone recipients. For SPK patients, survival was around 86% at 5 years and 71% at 10 years. And for kidney alone, around 87% at 5 years and 74% at 10 years. So kidney graft survival was also very similar between the two strategies. However, and again, with the previous study, early morbidity differed clearly. There was a higher rate of acute rejection within 1 year for SPK recipients, that was almost threefold higher, and also roughly a doubled rate of 1 year hospital readmission for SPK patients. So again, we see this survival neutrality overall, but with a higher early burden of complications for SPK recipients.
And yet in this study, there was a subgroup where the SPK appeared to retain a survival advantage. Can you describe that?
Yes, and this is an important point of nuance because they studied the subgroup of patients with type 1 diabetes and a low BMI below 30, and this is a classic SPK phenotype. And in this subgroup, kidney transplant alone carried a higher mortality compared to SPK. The adjusted hazard ratio was approximately 1.37 in favor of SPK. So in this particular, more homogeneous group, a survival benefit of SPK did persist.
So we have now two large contemporary analyses, one global EHR, one US registry, both suggesting that overall, once we adjust for selection bias, SPK and kidney alone have similar medium-term outcome in survival. So is this the end of argument that SPK improves survival, or is it more nuanced than that, as you already suggested?
Of course, I think it's more nuanced. First, we need to consider the time horizon. In these two studies, we had a median follow-up first for the EHR study of about 6 years, and in the SRTR data, most of the weight is in the first 5 to 10 years because they studied current era recipients. So we don't yet know whether the long-term follow-up up to 20 years of functioning pancreas graft will reveal some divergence in survival due to this better metabolic control and potential reduced macrovascular and microvascular complications. So this is the first point. Then we are in an era with what we have talked about, a big change in the landscape of diabetes management. So these new pharmacologic agents, these new technologies may have narrowed survival differences between SPK and an excellent kidney alone transplant with modern diabetes care. So we need more data also about this. And third, this analysis confirms that SPK is not uniformly superior. There appears to be a selective survival signal in classic type 1 lean recipients, whereas in a broader, more heterogeneous population, survival is essentially neutral. So here, SPK mainly confer metabolic and potential quality of life benefits. So I would say the survival argument is not completely over, but it is now more restrained and phenotype specific.
It seems to be a really interesting clinical dilemma because we also received 3 commentaries on these 2 papers. The first is an editorial by Lorenzo Piemonti, interpreting the neutral survival and the persistent metabolic advantages. Can you sum up his main message just quickly?
So Piemonti essentially accepts this survival neutrality at the population level when selection bias is minimized. But he's very clear that the metabolic superiority of SPK is not in question. So he argues that the response should not be to totally abandon SPK, of course, but to refine its indication, and that SPK, like we mentioned before, likely offers the greatest values in these younger, leaner type 1 diabetic patients, where survival benefit is still plausible and the metabolic gains are largest and for a long period of time during the lifespan of these patients. And he also stresses that those registry data don't capture several outcomes that matter deeply in clinical practice, which are the hypoglycemia burden, the glycemic variability, and the quality of life. Now, these patients who with SPK are going to be insulin independent. So he suggests that SPK should increasingly be viewed as a metabolic and quality of life intervention with possible survival benefit in selected phenotypes, rather than a universally survival superior strategy.
We also received a second commentary by Krishna and Krishna. They have a more defensive tone towards SPK. So how did they respond to this new data?
So they raised several important points. First, they emphasize that residual confounding in registry and large database analysis is unavoidable. Of course, critical variables are missing, such as duration and severity of diabetes, the burden of complications. Also, center expertise in SPK is not mentioned in those data. And they claim that it's difficult to claim that SPK and kidney alone recipients are truly exchangeable. That's their first point. And then they argue that SPK and kidney alone population are fundamentally different. So that's the constructing credible counterfactual. What if this SPK patient had instead received kidney alone is challenging and maybe would not be that accurate. Third, they highlight the subgroup finding from the Budijara study that in lean type 1 patient, the survival benefit for SPK persists. So they see this as a supporting ongoing use of SPK in appropriately selected candidates, which are the historical candidates for SPK. And then they stress an important physiopathologic point, that kidney transplant alone treats one complication of diabetes, which is renal failure, whereas SPK addresses the underlying metabolic disease. So being free of diabetes itself is a major outcome, even if short to medium term survival curves look similar. And finally, and this is an important also point, they warn against repeating the history of solitary pancreas transplantation, where negative interpretations of key studies led to marked decline in utilization. So it's a point of caution of policies and what we're going to do for transplant policies with those data.
Of course, the authors, they had the chance to respond to some of these critiques, and it's also published directly in the same issue. So what did they say to those things?
So Budi Raja and colleagues said they acknowledge several things. So they agree that SPK offers important metabolic and quality of life advantages, of course. They recognize the limitations of registry data, but defend this overlap propensity score weighting as an appropriate method when there is limited overlap between treatment groups. And their central message at the end is that these findings should lead to refinement and not rejection of SPK. Because survival benefit is not universal across all SPK candidates. There is a clear signal in the study for the subgroups of type 1 lean patients. And for other, maybe that SPK should be viewed primarily as a metabolic intervention with higher early surgical risk, requiring individualized counseling for those patients.
So bringing all of this together, it's two large contemporary data sets, different methods, broadly converging on the overall survival neutrality, with the metabolic advantage and the selection survival signal in classical type 1 lean patients. How should clinicians now frame this discussion with their patients?
I think this data help us moving from a blanket statement to a more personalized conversation. So instead of saying SPK improves survival, we may need to say something more nuanced, such as for younger lean type 1 patients, especially with a long life expectancy, a good surgical candidacy, SPK here is likely to offer post-metabolic and survival benefits and accepted this higher early surgical risk. For other patients, older patients with a higher BMI, with more comorbidities, medium-term survivals appears here to be similar between SPK and kidney transplant alone, but offers this durable near normal glycemia, the possibility of insulin independence. So this may translate in better quality of life, fewer diabetes complications. Also, these outcomes are not fully captured in these registries. But at the same time, this should be balanced with this higher early morbidity and more intervention, more admission in the first year. So it becomes a preference-sensitive, phenotype-specific decision, waiting between this early surgical and immunological risk. The value the patient also places on metabolic normalization, insulin independence, and their baseline risk profile and expected long-term benefit. How is the life expectancy of these patients?
So it's really a complex situation. And do you personally think that it might has also implications for organ allocation policies for SPK from ethical and also policy standpoints?
So it's a critical and very sensitive point, because in many allocation systems, SPK candidates have prioritized access to kidney pancreas offers. They have a shortened waiting time compared to kidney alone candidates. So effectively, this can lead to rethinking organ allocation policy, and it might be reasonable to reevaluate whether broad prioritization for all SPK candidates is still justified, or whether priority should be more tightly focused on groups where there is a real survival benefits against this lean type 1 phenotype. But this should be done with caution, with great caution regarding all this data. This is a complex ethical and policy question, and this brings evidence to start this discussion.
So to close the scientific part of our discussion, let me put a few open questions. So are 10-year survival curves enough to capture the vascular consequences of decades of normal leukemia?
So I think this is a very good point, because a longer follow-up might be necessary, because those patients are usually young. They have a chronic condition, type 1 diabetes, that will impair their long life expectancy. And I think long-term follow-up beyond 10 years is really needed to assess survival and cardiovascular outcomes in the context of a patient that will still be diabetic, or that will have an SPK with a functioning pancreas allograft with sustained normoglycemia.
Yeah, so we also need to integrate the pharmacotherapy of modern diabetes into the decision how to transplant.
Yes, that's a very good point, and a very important point, because we're seeing a lot of changes. It's new closed loop models for insulin delivery, this continuous glycemic control. This will lead to a way better control to diabetes, but it's not the same as a functioning pancreas. So we will need some studies to really see what is the survival benefits compared to these new technologies. And this is a current era, so we will need this data, but we will have to wait a few years to have them.
Maybe one last question. What is the acceptable trade-off between higher early morbidity and the promise of a long-term metabolic normalization and a better quality of life with it?
So again, I think it should be balanced regarding the patient phenotype, because a patient which is young, which have a strong type 1 diabetes phenotype with a lot of potential comorbidities that will appear along his life, will potentially benefit from this metabolic normalization with a pancreas transplant, and may also have a lower surgical risk compared to elderly patients. So this should really be balanced, and the patients, of course, should be informed of those risks, and should make the decision with all that in mind.
Thank you so much for this insightful comments. And for our listeners, if you like to dive deeper into the data and the debate, you can find the 2 original articles and 3 accompanying commentaries in the January feature of Transplant International on our website. So before I let you go, I like to switch topics for a moment. So Delphine, you're one of our Transplant International Editorial Fellows, and many of our listeners may be early career clinicians or researchers who are curious about this role. So what motivated you to apply for this fellowship, and what were you hoping to gain from the experience?
So there were many things that motivated me. So first, I wanted to improve my skills. Like in manuscript, for improving manuscript writing, you need to have a better also critical appraisal and manuscript reviewing, and it also allows me to go a lot through methodological reviewing of a lot of different study. I was also curious about how editorial decisions are made, and also I had an interest in contributing to the communities, the visibility of transplant research, and an interest to participate to this in Transplant International, which is the journal of the ESOT, so to our European transplant community. And I saw it also as a great opportunity to do some networking and some mentorship with experienced senior editors. So I think it's a very good way to enter the world of editing in a smooth way, in a way of learning that way.
Now that you're into the fellowship, like almost 6 months, how has the experience been so far? Was there anything that surprised you?
So surprised. So everything was new. So I don't know if I was surprised, but I have to point out that I'm really impressed of how each article is rigorously evaluated by the editorial team. We go to a rigorous discussion, and there is this rigorous discussion behind each decision. So we put a lot of attention to the methodological and clinical relevance. Of course, the methodological part is very important, but then we go beyond novelty and think, what will this change in practice or in thinking? And to do so we're not alone. And I appreciate a lot the feedbacks, the international collaboration with all the editorial team, and beyond the classical methodological drawbacks that would lead to a paper rejection. Of course, we have the opportunity then to discuss with the editorial team the relevance of the topic to help the decisions, because of course we all have our area of expertise, and I'm really learning a lot from that, from all other editorial team members to get a lot of experience about all the topics of the transplantation.
It's wonderful to hear. I also think it's a great experience. I wish it would have been there when I was a young fellow. And thank you so very much for today. I'm very grateful for your contribution to the journal and also to this episode. Thank you also to all of our listeners. Thanks for listening to the Transplant International Podcast, where science, innovation, and community meet. And don't forget to subscribe and hopefully join us for our next episode, coming soon. Bye.